All right, we're going to get our next session started. Got another virtual presenter here. So if everybody could have a seat, we'll get started. So we're staying on time. Okay, so I will somewhat introduce Dr. Carlson here, joining us from Legacy Emmanuel. And she's going to talk to us about geriatric trauma, which is probably not the least common trauma we see, probably the most common traumas we see, actually. So thank you, Dr. Carlson, for being here. And we will keep track of questions online and let you know. If not, we'll also let you know some questions at the end.
Great, thank you very much. Hopefully everyone can hear me pretty well. If not, let me know. My microphone has been going in and out, so definitely stop me if it does. But I'm sorry I can't be there in person. I am on call today here at Legacy Emmanuel. I'm one of the trauma surgeons on call for the ICU today. And although this is probably not the most exciting topic, I completely admit that. I do think it's probably a pretty relevant one in that this is a patient population we see every day. It really is very, very common these days, and I think it's a great topic to frequently review and find out what the updates are and what the new recommendations are. So my goal really in this is to provide some insight. Oh, I have no disclosures, by the way. So provide some insight into every level of learning here, hopefully. Hopefully everyone can find something interesting or find something that is new information or a good updated reminder for them through this. We'll go over with why do we care about the geriatric population specifically? Why has this been a hot topic recently in the past few years? We'll talk about specific physiologic differences, common injury patterns, as well as recent literature search on the pre-hospital data, what the updates are, and what's next in the pre-hospital care, and kind of take some guesses into new areas that I think are going to be explored that are pretty exciting. So I think we've all seen these, the changes in the population by millions of people from 1960 to 2060. So significant difference and significantly increased older population, and this is why we care. Trauma has always been defined as an injury of the young when we're talking about things like penetrating trauma. We generally say that, but with a growing elderly population, we're seeing more and more elderly trauma. And they need to be treated differently. It's a completely different category of patient population with different problems. And it clearly on this chart, it's ever growing. So from the 1960s to 2060, there's significant change in the swing of what our population looks like. This is a little personal story of mine. Just because I can't be there in person, I figured I should share some personal stories. So this is actually my daughter and my grandfather, so her great-grandfather. He's up there reaching 90, and this was in December. She was 6 months old. So interactions like this are really great. This is why I want to treat the geriatric population. I want to keep people like my grandfather around. Because in the 1960s, this wasn't something that was heard of. But in the same regard, when I do treat a geriatric patient, I frequently think of him and I think of how he would be treated if he was a trauma patient. So a couple of things that I always think about are, he's stubborn, he's stubbornly independent, he lives alone, he does everything alone, and he doesn't let us help him at all. He's in great shape, medically, physically, so that he can do that, but he is still approaching 9 years old. He's much slower to respond, so even in this picture, him getting down to sit on the floor with my daughter, is great to see, and it's great that he can do that, but he's not spry like he used to be, and just seeing that was a significant change. Again, he's stubborn, so he won't let us help him. He won't use a cane, won't use a walker to get up and down, won't even take a hand. He has some renal disease. He has some chronic kidney disease that's stable, but can affect the way that drugs are metabolized. He's stubborn in that if you ever asked him if he had any medical problems, he probably wouldn't tell you about his renal disease. He's on some antihypertensives. He has decreased muscle mass. He uses aspirin, cardioprotective, and he has some vision loss. He actually has macular degeneration, so he has no central vision. He mostly sees peripheral vision, but you would never know that because he is able to compensate, makes up for that, and has learned to use that. And last, he is so incredibly stubborn that if he ever fell at home, he probably would refuse medical treatment, refuse to say that he has any medical problems whatsoever, and continues to live alone. So, you know, thank God for modern medicine and keeping him alive, but at the same time, this is a very common geriatric patient that I think we see a lot. So why do we care? So geriatric patients with traumatic injuries are at higher risk for mortality and morbidity than younger adults. We've seen this over and over again in the literature. This is just a couple of articles that have found this findings in some really big studies and big journals. But they all agree that this special population of geriatric patients do have higher mortality, higher morbidity compared to their younger counterparts. And therefore, that's why it's important to treat them differently and to separate them and evaluate them separately. So some studies have looked into why do they think they have this increased mortality. And I think the important ones to look at are ones that either we can be more aware of or ones that we can act on and we can evaluate. So some factors leading to this increased mortality have been listed as the failure to properly triage. I am absolutely biased in this. I think we all can admit that. When we get a trauma activation for just another ground level fall, there is a sense of not a sense of urgency. Frequently the workup is negative, but I think this is a large part of why this subject is so important. Why are we activating all these ground level falls? Why are we bringing all these patients to trauma centers? And that's what this talk is really going to talk about. It is, you know, how can we help the bigger picture of geriatric patients? Senescence of organ systems. The organs are getting old. They have a limited lifespan. And so they're not going to act like they're 20 anymore, just like the patients. They have pre-existing disease states. So if you've reached 65 and have been able to completely avoid doctor's visits, I think you may be able to say you have no medical problems. But I think if you frequently checked in with physicians, you would have some level of a medical history at that point. So you've gained some sort of diagnosis at that point in time. And then frailty. So are these patients who are over 65 the ones that are leading to increased mortality, or is it just the frail population? And should we be looking at how frail patients are rather than their age? So that's a big hot word that's been circulating. So what do we do to identify the patients at increased risk of mortality? And what do we do to decrease that risk? So we want to thoroughly evaluate all the geriatric patients. And if we evaluate them at a trauma center, this actually improves their outcomes. So there's, this has been studied. And for seriously injured adults that are transferred to a level 1 trauma center, you can see a 20% lower in-hospital mortality and a 25% lower one-year mortality. So the data is clear that level 1 trauma centers are going to treat these patients in a different way that improves their mortality, and whether that means that they have additional access to things like physical therapy or resources for post-hospitalization, even more so than just the physicians that are treating the patients. That, you know, there are reasons to transfer patients to trauma centers. With that being said, I think everyone in the room can agree not every ground level fall can go to a trauma center. That's where we start talking about under triage and over triage. So we've set a goal that our under triage rate should be really less than 5 as a trauma community. This is to try and to ensure that no patient with a serious traumatic injury should go unseen by a trauma center. We have also accounted for an over triage goal of 35%. So this is much greater to be all inclusive, to say sometimes we may over triage a patient because we know that there's data to support that bringing them to a trauma center may improve their mortality. So we do allow for some over triage, but how do we differentiate between this some over triage, and how do we differentiate between bringing every single ground level fall to a trauma center? And I think that I am very happy in that I don't have to make that decision, but I think that's very pertinent to this discussion and to this group here. So I kind of wanted to talk about what the geriatric population looks like from a physiologic standpoint, differences, and then we'll go kind of into that, how do we triage them differently. So this is just a good review, a couple of keywords to keep in mind. The keywords are really the ones on the left, and they give a global perspective: declining cellular function, impaired adaptive and homeostatic mechanisms, increased susceptibility to any sort of stress of injury, and decreased physiologic reserve. That's a really big one. Patients can't respond to injury the same, they can't recover from injury the same, and they don't demonstrate the same response as younger patients when they are injured from an immediate evaluation standpoint. So this is a photograph of most of the organ systems. Don't even include skin on there, but that's another one of all the different ways that age can change the physiology of a patient. So with that change in physiology, we see a certain mechanism of injury, and we see a certain injury pattern that we're going to talk about a little bit. So falls, it's one of our most common ones, so it's also the most common mechanism of a fatal injury in the elderly population. So we talk all the time about things like gun violence and especially in the younger population and in children and accidents, and that's not the most common mechanism that leads to death in those populations, but not as popularized is things like ground level falls in elderly patients. And that being the most common mechanism of a fatal injury, this is really, if you are able to treat these patients and get them the appropriate care, that's a huge patient population you can make a difference in. So half of these deaths that are associated with falls are resultant of traumatic brain injury. There's reasons for this, and I'll go over that a little bit when we're going to talk about TBI specifically, but just some reasons why elderly people fall more often. So musculoskeletal weakness, poor balance, they have slower response time. So when an elderly person falls, they don't outstretch their hand like a younger person would. They don't protect themselves, so they're actually more likely to hit their head on the ground. They are not as strong. They can't stop themselves by grabbing onto things around them to prevent their falls. So it's reasons like this where not only are they more likely to fall, but they're also more likely to hit their head when they do fall. Other things to keep in mind are what happens once an elderly patient falls. So they're very cognizant of that, and a lot of times this leads to decreased mobility based on the fear of falling. So someone falls once at home, they're not going to leave the house as much. They're not going to get out of the house because they know what that fall means for them. And they have a fear of having it happen again. This leads to worsening mobility. This leads to, worsening gait, worsening strength. And it's quite a spiral that kind of spirals down when these patients do have this fear of falling. So another common mechanism is motor vehicle crash. Like I said, with an aging population, our drivers are aging. They have a slower reaction time. They have larger blind spots. They have limited cervical mobility, usually due to some atherosclerotic and as well as cervical disease. They have decreased hearing. Some have cognitive impairment. And when we look at motor vehicle crashes, we also notice that in the elderly population, there's more medical causes that precipitate the car accident. So we've had many patients who come in who are a single vehicle crash. On scene, they're found pulseless, CPR is started, and there's no real visible reason for the crash. So which came first? Was it an MI or was it a crash causing blunt cardiac injury? And a lot of times we have to hash this out, but it also gives an entire new level of difficulty when trying to treat these patients because the routes of treatment are very different in those circumstances, and it can be very confusing to sort that out. Also, in especially women, due to increased osteoporosis, there's a lot more fractures in motor vehicle crashes, even at slow speed, so thoracic fractures, and that can be ribs and spine, as well as hip fractures. And not only are elderly patients more likely to get these fractures, but they're also more likely to bleed from them. So in an isolated hip fracture, an elderly patient is much more likely to have bleeding and the need for blood transfusion than a younger patient. Burns is another mechanism that's been very well studied. There's actually a score that we use for patients who have burns. So it's the percentage of total body surface area burned, and it's also multiplied by the age. As that score increases, your chance of recovery is significantly lower. So it's very well documented that elderly patients do not do well even with recovering from much smaller burns than younger patients. Penetrating trauma is an interesting one. Unfortunately, we are seeing a rise in penetrating trauma of the elderly. And I think the biggest point I want to make about this one is it's not in the younger population, we see penetrating trauma most as inflicted by others. In the elderly, we actually see it inflicted upon oneself, so suicide or self-harm. So anytime you see an elderly patient with evidence of penetrating trauma, have that at the back of your mind that it's not common for elderly patients to have penetrating trauma except when self-inflicted. And then, of course, elder abuse, something to always be cognizant of, especially when you all are, the ones assessing the scene and the circumstances behind how these patients are injured. So here's a little bit more about some specific injury patterns. We have rib fractures. So there's a lot of chest wall changes, decrease in your functional vital capacity, decrease in your bone density. The chest wall just is much more stiff. It does not move as easily as in younger patients. So you're at significantly increased risk for these rib fractures. One of the most common complications from any rib fracture is pneumonia, and as high as 30% of patients do develop pneumonia in rib fractures. What we can do in the hospital for these is frequent pulmonary toileting. We can have close observation, we can monitor them, and we can ensure that they're not worsening in their care. The biggest thing that we do for these is actually just pain control, which when you have that for the elderly population, that's a pretty hard area where you don't want to cause delirium, you don't want to cause somnolence, but you do want to keep pain control. One area that has worked very well is things like epidurals or blocks for pain control, and where we can keep the opioid analgesics to a minimum and use alternative methods for the elderly patients to keep their pain under control. Something that's always quoted whenever we're talking about geriatrics and rib fractures is this mortality increase by 19% for each rib fracture, in addition to 2 in patients over the age of 65. So that's a significant number just by an additional rib fracture, and that's how poorly these patients tolerate these injuries. I mentioned TBI earlier. So patients are increased risk for bleeding. They are more geriatric patients are on anticoagulation or antiplatelets than the general population. And there are some reasons why a geriatric patient may not present like a younger patient. So I have pictures below A and B. So in B, that's a normal brain. You can see the gray-white matter of the brain that fills the skull cavity pretty well. You can see the black portion, which is the cerebral spinal fluid around the brain, as well as the ventricles in the center. In A, you see the gray-white matter is significantly decreased. So that's cerebral atrophy. That comes with aging. And things like stroke can hasten that, but generalized aging leads to the cerebral atrophy. You see there's a lot more cerebral spinal fluid surrounding the brain, and that's that black portion. What can happen when a patient is injured, because they are at increased risk from things like anticoagulation, antiplatelets, as well as increased risk because the dura that connects the brain to the skull is actually much stiffer in an elderly patient. When that moves, so the brain is able to move much more within the skull. Because that dura is stiffer, it tends to rip and cause bleeding. The patients then bleed into that space between the brain and the skull. In the normal picture on B, you can see there's not a lot of room for that bleeding to occur. What happens is the mass of the brain actually gets compressed, and that's where we identify clinical evidence of TBI. So that's where we identify altered mental status or change in your pupillary size. Where in the geriatric patients, they have a lot more room before that compression occurs. They also have minimal reserve, which we'll see over and over again as we go through this. And you won't initially see that change in their pupils. You won't see a depressed GCS as quickly as you will in some other patients. So there are these confounders where geriatric patients may look totally fine initially, and it may not be till later that they really start to decompensate. Another common is pelvic fractures. So pelvic fractures alone present with 4 times higher mortality in geriatrics. They have a significant higher need for blood transfusion, which I mentioned before, and they're less likely to return to independent lifestyle. So the problem with pelvic fractures, so you look at this image, and you can obviously see multiple points of fracture. The bones are thinner. A lot of times patients have some level of osteoporosis just from aging. And in order to fix these pelvic fractures, it's a significant surgery. So there's a risk of anesthesia, post-op delirium, pain medication, all of that puts higher risk. And then there's also the risk of the fracture fixation not holding. So what we have to do is we have to actually screw in metal plates and screws into this bone and hope that the bone holds. In the osteoporotic bone, it doesn't always hold, or you can actually start screwing and have splintering further of the bone. So if the patient has a stable pelvic fracture, so on the, what would be the patient's left side there, the acetabulum is broken. That usually requires surgery. On the right side, it's just the pelvic ring. So sometimes we can tell patients it will heal, you can still bear weight, but then you have a geriatric patient who's in significant pain, who you don't want to give too many narcotics to because you don't want to induce delirium, who is at baseline weak, is at baseline unsteady, and now you're telling them to try and walk on their broken pelvis. So unfortunately, these injuries really are just a gateway into some sort of rehab or skilled nursing facility, unfortunately. And patients just don't recover from them as quickly as a younger patient can. So how do we get our patients to the ED? So we know that treating geriatric patients in level 1 trauma centers is improved in morbidity and mortality. But how do we decide which patients to bring in an expedited manner? Because we can't bring all patients. So I think from the second that you see a patient, there already have been documented in the literature that there's potential care delays even before EMS is activated. There's documentation that patients who live in skilled nursing facilities actually have a delay time just even to EMS activation. So these patients are already behind when EMS is activated alone. And some of the thoughts behind that are there's certain protocols to follow. The patients may not be found right away, depending on how much observation they have at that facility, or it may be just another ground level fall and the patient is observed for a period of time before EMS is even activated. Once EMS does arrive, these patients require a much more extensive assessment. Whereas a 20-year-old can tell you they were snowboarding down the mountain, they crashed into a tree and their right leg hurts and they have no medical problems, a geriatric patient may not be able to provide you that information, may not remember nor know what happened, may not know their medical history, and it may require a lot more interviewing just to get the information that's needed from them. Or in the case of someone like my grandfather, if he was ever called, refusal of care. It's actually documented that geriatric patients refuse transfer to the hospital more than younger patients. And, you know, I can see where this comes as a geriatric patient. You also are saying, oh, it's just a ground level fall. I'm okay. You know, no one wants to come visit us in the hospital. I understand that, but I think it's up to us to be able to assess these patients and determine, is it truly just another ground level fall, or do they really need to come and be seen? Once you arrive to the patient, there's also some considerations in treating the geriatrics. So pre-existing conditions is going to change everything you do. By the time that you're over 65, like we talked about earlier, you're likely diagnosed with at least one medical condition, and that's going to change your exam compared to someone with no medical problems whatsoever. So some of the specific points to think of when you're assessing a geriatric patient on scene is the airway. So there is actually some reports that sometimes if a patient has dentures that are fitted well and remain in place, it actually can help you when you're bagging a patient, keep that airway open. When they're edentulous, bagging can be a lot more difficult. So something to keep in mind is dentures. That being said, poorly fitting dentures or dentures that are not in place can also block the airway sometimes. So looking for that and ensuring that those are removed if needed is important. Geriatric patients just have a loss of the protective airway reflexes. That's why we see so much more aspiration pneumonia in the older population. They also have arthritic changes in their neck that prevent them from being able to be fully extended and get an easier view of the airway. With all of these, it's pertinent to think maybe a little bit earlier about securing a patient's airway, or about if they do decompensate further, how are you going to do that and how difficult will their airway be? Breathing. So we talked about changes in lung compliance when we talked about rib fractures. They also have a suppressed heart rate response to hypoxia. So they won't develop a tachycardia necessarily when they become hypoxic. They might not change their heart rate until they become bradycardic right before having a cardiac arrest due to hypoxia. Part of this is due to a lot of elderly patients being on antihypertensives. Others is just they have a decreased ability to change their cardiac output. Decreased mucociliary clearance, again, that's just part of the aging population. And then when we talk about their circulation, again, they have a fixed heart rate. They can't change their heart rate in response the way that a much younger person can. And cardiac output, same thing. This is mainly based off of their heart rate, so they can only provide so much cardiac output. Even if they need more, they're not able to make up for that. Majority have some sort of hypertension, treated or untreated. Those who are treated, then we actually define hypotension as less than 110. And we'll talk a little bit more about this. And disability. So the cerebral atrophy we talked about, we don't always know what someone's mental status baseline is. And then as well as the degenerative spine disease and exposure. So they have less subcutaneous fat. They may have nutritional deficiencies. These all lead to hypothermia much more often and much quicker. So that was just somewhat of a review. I think a lot of that's not new information for anyone, but I thought let's kind of look at the literature and look where we're going from here. So I did a literature search for geriatric trauma population, specifically pre-hospital, from 2019 to 2023, and there's a couple articles that really show that this is an emerging topic and that in the trauma community, we have defined this as a topic of interest. We have defined a couple areas that we can work on, and then have also had some advances. So this is a really good review, challenges in the pre-hospital emergency management of geriatric trauma patients. This is a review of multiple articles, and it does give a good background of the physiologic changes and all that. So I just put this up in case anyone was interested. So this one, Epidemiology of Geriatric Trauma Patients in Norway, a nationwide analysis of Norwegian trauma registry data, 2015 to 2018, retrospective study, and this was published in 2020. This is a little bit more interesting because the Norwegian trauma system is actually publicly funded. It is standardized across the board. They have a national registry, and yet despite all that, there is significant difference in how they treat geriatric populations as well. So they found a 14% 30-day mortality in over 65 and only a 3% in younger. They also had a significant amount of under triage, so less trauma team activation, 90 versus 73. And they also had increased time from alarm to hospital admission, so 71 to 78. So all the things that we're seeing here and we're identifying are really across the board, even in trauma systems that are very well organized. This was the most interesting to me. If you read anything from this presentation, I recommend you do read this article. It's a very easy article. It's pretty straightforward, but this makes me think about the bias that I have for geriatric population. This was in the American Journal of Surgery just in 2022. Disparity in pre-hospital scene time for geriatric trauma patients. So what you see below, 16,000 EMS responses to adult patients with traumatic injuries. Geriatric patients have prolonged pre-hospital scene time, which they define as greater than 10 minutes compared to younger adults. And the risk of increased scene time is, the odds ratio is 1.78, so that's significant. They attributed this to maybe delayed recognition of injury or cognitive bias. So not thinking that the geriatric patient was actually injured severely and that didn't need to get to a trauma center urgently. So this is from, I have to look how this is, National EMS Information System Public Release Research Data Set. So I wasn't aware, but there is this data set, which you might know more of, from EMS agencies across the US. It's publicly accessed, and it's de-identified data, and they looked at this. So this is across the board in all of the US. So it's a really encompassing study. And I think it points out that we may have this implied bias, and how can we overcome that? And if you look at even the higher age groups, so when you get up to age 80, your odds ratio is 2.66, so even higher. So we're not responding to older patients as quickly as maybe we should be, when we know that quicker response time and getting them to a trauma center improves their mortality and morbidity. So how can we improve the outcomes of these patients? How can we decrease the under triage? But also, how can we keep the over triage minimal? Again, we can't bring every patient to a trauma center, and we can't expedite the care of every single patient who falls. So luckily, there are some guidelines. So this is a national guideline for the field triage of injured patients. This is published by the American College of Surgeons Committee on Trauma. The last publication was in 2011 before this update in 2022. And this is updated about every 5 years or so. What they do is it's a panel of experts that sit down, look at all of the recent data and decide, is there any new data in trauma care that can help us identify those patients who are high risk for serious injury? And just going over the geriatric portion of this, we'll dive into where this data came from and why these are the new recommendations. You all may have seen this multiple times, but I think what's important is to say, I understand why they're making that recommendation. I know what population to make that recommendation in, and I can figure out how to apply that to my everyday. So in the box on the right, on the bottom portion, you see age greater than or equal to 65. So patients with a systolic blood pressure less than 110 or heart rate greater than systolic blood pressure are recommended to be triaged to the highest level trauma center available within the constraints. So this is one of the studies where they identified these data points. So the heart rate greater than systolic blood pressure, we're talking about the shock index. And what this identified was that the shock index showed a sensitivity of 37% in out-of-hospital studies, and that this was a acceptable level of a criteria that we can use to encompass anyone who may be at risk for a serious injury. They also did this with out-of-hospital respiratory measures. The first one was cardiac measures. This was respiratory. They weren't able to find any clear consensus about any respiratory measures that we can identify pre-hospital. So specifically, this is another article that goes into this a little more in depth, the impact of age and receipt of antihypertensives to systolic blood pressure and shock index at injury scene and in the emergency room to prevent massive transfusion in trauma patients. So this is in 2021. What this was 1 year at a level 1 trauma center. They did a retrospective review of all of their patients. They found that they had it was 1,949 patients who met criteria. Of that, 660 were on antihypertensives, so a good portion of patients. And what they found was those who were taking antihypertensives, if you used a systolic blood pressure of 110, then anyone under that was at a significant risk of needing blood transfusion. So this graphical representation, the lighter box is non-antihypertensives. The darker box is the antihypertensive patients. And then on the left axis, you see the PRBC is transfused, and then on the bottom axis, that's based on the systolic blood pressure. So we see a significant difference if the patient is over 110, which is the one all the way to the right, versus just to the left of that, the 90 to 110. So on any systolic blood pressure under 110 in patients on antihypertensives shows a significant portion of those patients require blood transfusion. And so that is why that we look at this marker now and have added it to our criteria. Another marker that had been added to the criteria that was changed a little bit as well is this EMS judgment. So you see risk factors, including low-level falls in young children or older adults with significant head impact. So this can be interpreted in so many different ways. So I'll read you what the committee thought when they were writing this. So they wrote that for older adults, ground level falls can cause serious injury and death. Ground level falls are more common in older persons and relatively non-specific for serious injury. Therefore, adding with significant head impact, they were hoping to allow EMS judgment to account for the fact that elderly patients who do have significant head impact are at higher risk for traumatic brain injury. This leaves it, if concerned, take to a trauma center. And I think the significant head impact and having the idea that that patient with a fall, what are they at risk for? They're at risk for injuries of their spine, their thoracic spine. They're at risk for traumatic brain injuries. If you can accurately assess them and deem that they do not have significant risks of having those, great. If there's any question or concern, then they should be treated at a trauma center because they may have those injuries that they are at a much higher risk of just by being over 65 and having a fall. The other one here is anticoagulant use. And we'll have a little bit more, but they deem that to have relatively low predictive utility. So I thought this was very interesting, and I think there's going to be a lot more on anticoagulation and ground level falls, just even after the publication of this recommendation. So this was in 2019, comorbidities, anticoagulants, and geriatric specific physiology for the field triage of injured older adults. So what this shows, so this was a review of 2,000 patients. And what they did was they used so this is a very busy slide, I apologize, but if you look all the way on the left, you see current triage guidelines. So that was the triage guidelines in 2011. And then if you add a GCS score less than or equal to 14, and then add the geriatric specific vital signs, which we already discussed, then add comorbidity count greater than or equal to 2, and then add oral anticoagulation use, you change your sensitivity, which means how many injuries you include, from 37% to 94%. And that's similar, and they're looking at mortality, they're looking at 1-year mortality, and then they're looking at injury for each of the different injury zones. And all of them increase a significant amount just by adding those GCS, vital signs, comorbidity, and anticoagulation. What this paper did show is that adding anticoagulation actually did not increase it above the marker of what they identified as being meaningful. So all of the others identified it significantly that they are recommending those be added, those be at least thought of when we're talking about if the patient should go to a trauma center, whereas anticoagulation, so use, did not actually increase it as much. So that's why it's left open for EMS discretion, and it really is based on what the patient is looking like, and I think that's where a lot of that EMS discretion comes in of we know the patients who do have head injury or do have bleeding on those medications really do benefit from reversal when those injuries are identified, even if our data doesn't necessarily support that we're capturing more injuries when we're adding those values. So all in all, I think, reading through, I'm just going to go back for a second. So reading through these red criteria, which means definitely transport to a trauma center. And then the yellow criteria includes EMS judgment and understanding why they made those changes and what they're really looking at, what the data says, I think brings it into a different perspective, especially when you're all the ones utilizing these criteria as your judgments. And I think it's important for you to know where they came from and what the data actually says about them. So what's next? So this is just some thoughts based on some research, as well as some things that have just been kind of talked about within the community. So frailty. So this is always mentioned whenever we talk about geriatrics. Should we base guidelines off of age, or should we base guidelines off frailty? This is a very simple version of a questionnaire that can assess if patients are frail. Are you able to use the toilet? Are you able to get dressed? Are you able to handle your own money? So just a series of a couple questions can determine. There's ones that are much more in depth. They include grip strength. They include chair, get up, it's called get up and go. So chair to standing and how quickly you can do that. And there's ones with 40 or 50 questions. There's just a lot of frailty markers out there. And here's one example of a paper that they actually looked into a frailty assessment pre-hospital. So in the bottom, I think the important one to point out is 1, 2, 3. So the fourth bullet line, second one from the bottom. The ambulance job cycle time was 8.9 minutes longer for patients who were assessed using just even this questionnaire. So we have data supporting quickly bringing patients to the emergency room. That's both in penetrating trauma and geriatric trauma, just in trauma across the board, getting patients to definitive care. But this frailty score is going to add a whole 9 minutes on, which is a decent amount of time. With how often a geriatric patient is the one using the ambulance, this can significantly increase, I think, the minutes in the day that are that may not necessarily change their outcomes. So this didn't look at if this in any way changed their morbidity or mortality. So it's a nice thought. I don't think it necessarily works very well when you try to integrate it into our current way of identifying patients. And then this is just, so in doing this literature review, what I thought was great was all of these published papers in different parts of the world that do state that we understand that we need more research in this area. So this one's out of England, so they call it silver trauma instead of geriatric trauma, which maybe we should adopt here. I think that's a great name. But they determined that more research needs to be done on this. This is an ever-evolving topic that just even a few years ago didn't have as many patients as currently. This is the US version of that same idea. So the Delphi survey, so this is a panel of experts. The geriatric trauma panel includes trauma surgeons, it includes geriatricians, epidemiologists. There's a wide range of people who are involved in this. And what this is a group of experts getting together and identifying where are our gaps and where should we recommend that further research be done and what kind of research should we support at this point. So they identified for the geriatrics pain management, frailty, anticoagulation related interventions. Those are the big topics where we really have a research gap, and that what they did is they then, they set up a recommendation to the National Institute of Health, where they will continue to support research based on these specific interventions that they're interested in. And then this is just another third article with a similar overall understanding that research in this area is minimal, and this is in Australia. So they looked at research priorities in emergency care and identified geriatric trauma as one of the areas where they really feel that research needs to be done and that we need to be promoting this. So my overall recommendations, taken from someone who I think at times definitely does not understand the struggle of the pre-hospital decisions, but who also has similar bias, I think, sometimes when we see geriatric patients. But I think we have to respect our elders. So respect them in that they have been through a long life, and just as they have, their organs have. They're not what they used to be. They cannot tolerate what they used to be able to. And we really need to understand those physiologic differences that come with aging. And we need to be knowledgeable of that. We need to know how they're going to respond differently to trauma compared to younger patients so that we can make a better assessment and recommendations and get them to their definitive care. This one is always interesting, of just understanding what is their baseline. Are they on antihypertensives? Are they on anticoagulation? Do they have a baseline of dementia? Do they have a history of stroke and they're unable to move one arm or leg? All of this information is very helpful, with the caveat that we know that decreasing transport time and getting the patients to the definitive care where they can get things like imaging, anticoagulation reversal, surgery, all of that will change their morbidity and mortality, but also having this kind of information is extremely helpful. Minimizing scene time, again, that's documented that is helpful, getting these patients to their definitive care. Again, for the elderly patients, one of the biggest ones is that anticoagulation reversal in those patients who are found to have head injuries. It's very well documented that the quicker we're able to do that, the better their outcomes. Consider the field triage guidelines. Again, they're guidelines. They are heavily made by some of our Pacific Northwest groups, so I think they are very appropriate in kind of our setting, and I think they're great to understand, to use, again, as a guideline. But I think it also helps to take some of the bias out of patients. A patient may look great, and sometimes that might not be enough. They may be harboring something that we can't identify, and we're not going to be able to identify all of them. So using something like a triage guideline can help take some of that bias out of it. Feedback after ED initial evaluation. So there was a study saying that EMS crews who actually requested feedback helped them in the long run make better clinical decisions for who to activate. So you think in our hospital, I understand how busy you absolutely are, but you drop another patient off shortly after, it completely appropriate to ask, how did that patient do? Did that patient who I thought had a pelvic fracture, did they actually have a pelvic fracture? That patient who was altered, did they have an intracranial hemorrhage? And getting that feedback, because a lot of times you don't. A lot of times you drop off a patient and not really sure exactly what happens to them. And I think that closing that loop and being able to have that educational value helps your own ability to then use that experience when you see the next patient. So some questionable points, that there has been some data, so some of those papers I presented early are talking about things like end-tidal CO2, point of care lactate, heart rate variability. The end-tidal CO2 we do use, but we don't use on everyone. The point of care lactate, it's becoming easier and easier without needing a full lab to draw a small lab and have a full set of base deficit and lactate and pH almost immediately. And then heart rate variability. We have a lot of external ways of determining this, and that can give you insight into intravascular volume. So in hemorrhagic patients, this could be very helpful. Something that has not been as well documented for geriatrics, but is documented for just generalized trauma, is also point of care ultrasound. So the fact that we can have ultrasound probes we can keep in our pockets and hook up to iPhones now can help in things where we're assessing intravascular volume. So in an elderly patient, we can look at their IVC to determine if we think that they're really dry. We can use that to do fasts on motor vehicle collisions to determine if there's any splenic bleeding. So I think all of these bringing the ED evaluations to the scene are really going to be kind of the next step of, do they make a difference in the overall care of the patient? We know we can do them and we know we can bring them. It's just going to say, although we find a problem or identify it, are we still able to get the patient to what they need, their definitive care? But I think all of these are going to be really interesting in the next few years. Everyone may not agree with this, but my feeling is, given all the things I presented and all the problems you can have with being a geriatric patient and having a traumatic injury, if in doubt, over triage. So we do allow for higher over triage rates because of that. We do want to identify these patients, and these patients don't have a reserve. They do not do well if we're already behind the marker when we actually get to them. I think there's a lot to be said by there's just something off in a patient sometimes where you see them and you just say they don't look good, something's going on. And I think that's a very respectful thing to say when you're just saying, you know, they don't meet the criteria, they don't fit exactly, but this patient needs to be evaluated and this patient needs to be seen. And I think coming from people who have experience in healthcare, that's just going to grow over time, and that is enough, in my opinion, to activate a patient, get them to a trauma center, and get them what they need. So I appreciate all the work that you guys do, bringing the patients to us, and happy to kind of answer any questions. And yeah, if you have any further questions, if you ever see me at Legacy, if you bring us some patients, say hi, and I'm happy always to chat about these kind of topics. Just scrolling through some of these questions. Yes, getting meds written down, completely agree. I think being aware of which medications are going to be pertinent based on that patient. So in a geriatric head injury fall, things like antihypertensives, beta blockers, anticoagulants, antiplatelets. If you can identify those, that would really be helpful. Other medications, completely understand. Things like psychiatric medications or seizure medications in a patient who's altered. Those help a lot because then we can actually get levels on those patients and see if they're therapeutic when they come in. Have they been taking their meds? Are they overly sedated? So I think that is completely understandable, but I also think it's very helpful from us, and we do always appreciate that. All right, well, there's one about a CDC study that sounds very interesting. So we will see. It looks like it's studied in Oregon this year. I think a lot of geriatrics come from Oregon because of our Seattle partners. So that's great. All right. Well, thank you, everyone. Like I said, always reach out to me if you have any further questions.